All right, future orthopods. Let's get into some pretty meaty topics today. Open fractures and mangled limbs. I mean, this is like bread and butter for those postgraduate exams, right?
Absolutely.
This deep dive is based on the Ortho-Made Simple Notes from mokyingren.sg.
Okay.
These notes are put together by Dr. Mok Ying Ren.
Uh-huh.
He's a sports surgeon at National University Hospital in Singapore, and he just aced his FRCS in 2022.
Wow.
So, I think we're in good hands with these notes.
Yeah.
So let's say you're in the ED, right?
Hmm.
And a patient comes in with an open fracture.
Mm-hmm.
What's like the first thing on your mind?
Oh, the first thing that pops into my head is time.
Okay.
Specifically that 3-hour window
Okay.
to get the antibiotics in.
Okay.
The Bay-Prowse guidelines are really clear on this.
The British Association of Plastic, Reconstructive, and Aesthetic Surgeons.
Yes.
Got it.
You miss that window and you're looking at increased infection risks.
Okay, so 3 hours.
Yeah.
That's crucial.
Yeah.
Talk to me about the antibiotics. What are we giving? And does the contamination type change our approach at all?
Okay, so initially, it's IV augmentin or cefazolin.
Okay.
And after the first debridement, we usually switch over to cefazolin plus gentamicin.
Okay.
But you're right, contamination does make a difference. So
Yeah.
for marine contamination, we add doxycycline
Okay.
because we're worried about Vibrio vulnificus.
Ah, I see.
Now, if the patient has a penicillin allergy, we'll switch over to IV ciprofloxacin or levofloxacin.
Okay.
Freshwater contamination, you got to think about Aeromonas hydrophilia.
Yeah.
Again, ciprofloxacin or levofloxacin are your go-tos.
Okay.
And then for soil or fecal contamination, we also add metronidazole
Okay.
to cover Clostridium and anaerobes.
Wow. So much to remember. Okay, so the antibiotics are in. Now, what about wound care in the ED? Are we doing any bedside debridement?
No. The key in the ED is less about doing things and more about documentation.
Okay.
Clear photographs are going to be your best friend here. You put on a simple, moist dressing, and that's all you need at this point.
So no bedside heroics.
No. You save all of that debridement for the OR.
Okay.
Got it.
Speaking of the OR, what about irrigation? High pressure all the way, right?
Not necessarily. The Bondari FLW study,
Okay.
which was a landmark trial published in the New England Journal,
Right.
showed that low-pressure irrigation is just as good as high pressure when it comes to preventing reoperations.
Okay.
Plus, you should really ditch the soap.
Really?
Yeah. That same study actually showed higher reoperation rates with soap irrigation compared to just plain saline.
Wow. Interesting.
So, saline, low pressure, keep things nice and simple.
Simple is good,
Yeah.
especially when we're juggling so many things.
Right.
So the wound is irrigated. Now we need to figure out what tissue is viable. How do we assess that? I mean, especially those postgraduate exams coming up.
Right. So for muscle viability, remember the 4 C's.
4 C's. Okay.
Color, consistency, contractility, and capacity for bleeding.
Got it.
For bone, you look for the paprika sign.
Paprika sign.
Yeah, it's that punctate bleeding you see on the surface of the bone.
I see.
It's a good sign that you've reached healthy, viable bone.
Paprika sign. I love these descriptive terms. Okay, now what about those pesky fracture blisters? It seems like they pop up all the time with these open fracture injuries. What's the best way to manage them?
Fracture blisters are interesting. You see both the clear fluid-filled ones and the blood-filled ones.
Right.
Both arising from that dermoepidermal junction.
Yeah.
There's really no clear consensus on the best way to manage them, leaving them intact, de-roofing them, or aspirating them.
Okay.
They've all been studied,
Yeah.
and there's really no significant difference in outcomes.
So what's the key takeaway for us as we're prepping for these exams?
I would say focus on minimizing complications.
Okay.
Try to avoid making incisions anywhere near those blood-filled blisters.
Okay.
They tend to be more problematic.
Noted. All right, so we've covered the basics of open fractures. Let's shift gears to something a little more intense. Mangled limbs.
Okay.
How do we even begin to approach the decision between limb salvage and amputation?
This is where things get really challenging.
Yeah.
It's not just about your surgical skills anymore. It's about patient expectations, ethics, long-term outcomes. It's a lot to weigh.
Yeah.
But thankfully, we have some research to help guide us, like the LEP study.
OEP study?
Yeah, short for Lower Extremity Assessment Project.
Okay, tell me more about the LE study. What did they find?
Well, this was a huge study published back in 2002 in the New England Journal of Medicine.
Okay.
They looked at over 600 patients with mangled limbs. And what they found was really surprising.
Oh,
There was no significant difference in long-term functional outcomes or quality of life between those who underwent amputation and those who had limb reconstruction.
wait, so it doesn't matter which path we choose. Amputation versus reconstruction, equal outcomes. That's pretty shocking, isn't it?
It is. But there's a catch.
Okay.
The reconstruction group went through a lot more.
Right.
More surgeries, more complications, longer hospital stays.
Mhm.
It's just a much tougher road for everybody.
So if the long-term outcomes are so similar, how do we even begin to make such a weighty decision? What factors should we even consider?
Well, that's where these scoring systems come in.
Okay.
The MES score,
PES score.
which stands for Mangled Extremity Severity Score,
Okay.
and the Ganga Hospital Score. Those
Oh.
are two of the most commonly used.
All right, let's break down these scoring systems. What do they look at, and how do they help us make sense of this really complex situation?
So the MES score,
Okay.
it looks at 4 key things.
Okay.
Skeletal and soft tissue, injury severity, degree of ischemia, presence of shock, and the patient's age.
Okay.
You add up the points. And a score of 6 or less generally favors limb replantation,
Okay.
but 10 or higher.
Yeah.
Amputation might be the better choice.
Okay.
The Ganga Hospital Score.
Yeah.
That digs a bit deeper. It looks at skin, bone, muscle units, and any comorbidities.
No.
Out of 29 points, 14 or less suggests limb salvage,
Okay.
while above 17 leans towards amputation.
So these scores, they help to guide us.
Yes.
But what about specific situations? Like, let's say a patient comes in with an insensate foot. Is that an automatic indication for amputation?
You would think so, but not necessarily.
Right.
Yeah, there was a study done in 2005 by Bose that looked at patients with insensate feet after trauma, and they found that over half of them regained sensation within 2 years.
Wow. Really?
Yeah.
So even with severe nerve damage, there's hope for recovery. That changes things.
Yeah, sensory status alone shouldn't be the deciding factor.
Okay.
We need to look at the potential for recovery.
Well, absolutely.
I mean, this is where those late-night study sessions come in,
Yeah.
and really understanding these nuances,
Right.
especially for your exams.
Yeah, this is all so much more complex than just looking at a score.
Exactly, and to add another layer, there was research that showed that mangled feet,
Okay.
requiring free flaps for reconstruction,
Yeah.
they often have worse outcomes compared to baloney amputation or salvage with a typical skin flap. This was from Ellington's analysis of the LEP data. Important stuff to know.
Yeah. It sounds like there's no easy answer, like no one-size-fits-all approach. Every case is unique.
That's the reality of trauma surgery. It's about carefully weighing all the factors, considering the research, and then individualizing that decision based on the patient in front of you.
This deep dive is definitely helping to connect those dots. Before we wrap up this part of our discussion, let's shift gears a bit and talk about skin reconstruction.
Yeah.
What's the deal with this reconstruction ladder concept? I remember hearing about it back in med school, but always good to have a refresher.
Sure. Think of it like a step-by-step guide to help you decide the best way to cover a wound.
Okay.
So like at the bottom rung, you have simple dressings. But when you have exposed bone or tendon or even like implants, you need to climb up that ladder to flaps.
Okay.
Because flaps have their own blood supply,
Right.
which is really important for healing in these more complicated cases.
Okay, so flaps for the big guns. But what about grafts? When are those the right choice?
So grafts are basically like little patches of skin that we take and transfer to the wound.
Right.
They depend on the surrounding tissue for their blood supply.
Mm.
So they're best for these less complicated wounds where the underlying structures are still healthy.
And I remember there are different types of grafts, right? Split thickness versus full thickness.
You got it. Split thickness skin grafts, they come from the more superficial layers of the skin,
Okay.
and they actually have a higher take rate because they don't need to reach as far for those nutrients.
That makes sense.
Yeah.
What about full thickness grafts? What are their advantages?
So full thickness grafts include all the layers of the skin,
Right.
and while they can be a bit trickier to get to take, they offer a few key benefits. Better sensation,
Okay.
less scar contracture,
Mm.
and they're just tougher, more resistant to those shear forces.
Interesting. So we pick our graft based on the wound and what outcome we want.
Yeah.
But once that graft is on the wound bed, how does it actually integrate and take What's going on at that cellular level?
Yeah, so it's actually a pretty amazing process. First, you have fibrin adhesion, where the graft literally glues itself to the wound bed using fibrin.
Okay.
Then comes imbibition.
Imbibition.
Yeah, where the graft soaks up nutrients from the surrounding plasma. This happens over the first couple of days.
So fibrin glue, then a nutrient bath.
Yeah.
What's next in this little cellular dance?
So around day 4, you start to see anosculation,
Inoculation.
where these tiny capillaries start to connect the graft and the wound bed.
Okay.
Then by day 5, neovascularization kicks in.
Yep.
Brand new blood vessels start forming to actually feed the graft.
So it's getting its own dedicated blood supply.
Exactly. It is.
That's incredible.
And finally, reinnervation begins. Sometimes as early as like 2 to 4 weeks after grafting.
Wow.
That's when those nerves grow back and start restoring sensation to the area.
Wow. So much happening underneath the surface there. But with all these kind of intricate steps, what are the big complications we need to be watching out for after we've done the grafting?
Well, infection's always a concern, especially with these complex wounds.
Really?
We also worry about shear stress,
Yeah.
which can disrupt that delicate healing process if the graft moves around too much.
Yeah.
And of course, hematomas
Okay.
underneath the graft, which can prevent it from properly sticking to the wound bed.
Got it. So infection, shear, hematomas, the trifecta of graft complications.
Pretty much, yeah.
And before we move on, let's revisit those flap classifications.
Okay.
You mentioned different ways to categorize them
Yeah,
based on their configuration, tissue type, and circulation.
right.
This feels like prime exam material.
Absolutely. So configuration refers to the shape and how we actually move the flap. Think like rotational flaps, transpositional flaps, advancement flaps. Tissue type.
Okay.
That's all about what the flap is actually made of. Muscle flaps, fasciocutaneous flaps, even bone flaps if we need them.
Okay.
And then circulation. This is key.
Yeah.
So free flaps, they're completely detached,
Okay.
and they require microsurgery to reattach them.
Right.
Whereas pedicled flaps keep their original blood supply
Okay.
through an artery and vein.
Okay, that's a really helpful framework. Can you give us some quick examples of some common free flaps in their blood supply?
Yeah,
Just so we can solidify that knowledge a bit.
sure. For lower extremity reconstruction, the anterolateral thigh flap,
Yeah, ALT flap.
or ALT flap, that's a workhorse.
Yeah.
It's supplied by the lateral femoral circumflex artery perforators,
Okay.
the gracilis flap.
Yeah.
Another popular choice, fed by the medial femoral circumflex artery,
Okay.
the latissimus dorsi flap, or lat flap, great for larger defects, relies on the thoracodorsal artery.
Okay.
For upper extremity reconstruction, you've got the radial forearm flap, supplied by the radial artery. And when you need bone, the fibula bone flap, based on the peroneal artery, that's a good one.
That's a lot of flaps to keep straight. But it's amazing how we can literally, borrow tissue from one part of the body to rebuild another.
Right.
This is the kind of stuff that reminds me why I went into orthopedics in the first place.
Yeah, it really is remarkable. And don't forget, this whole deep dive is based on the OrthoMade Simple Notes.
Right.
From mokyingren.sg. Dr. Mok did a fantastic job compiling all this high-yield information for exam prep.
Absolutely. Definitely worth checking out.
Yeah.
Now, let's shift our focus back to those high-stakes decisions. Limb salvage versus amputation. We've talked about the scoring systems. But how do those scores actually play out in the real world? What are the nuances we need to keep in mind?
Well, you have to remember, scoring systems are just guidelines.
Yeah.
They can be helpful for getting a general sense of, the odds, but they don't tell the whole story.
Right.
You always have to consider the individual patient,
Yeah.
their overall health, their specific injuries, and you know what their goals are for the future.
Right. It's not just about saving a limb.
Right.
It's about giving the patient the best possible quality of life. And that's not always such an easy equation to solve.
No, it's not. And sometimes, even when the scores suggest that limb salvage might be possible, the patient might decide that, amputation is the best choice for me. It's a very personal decision.
Yeah.
And we have to respect their autonomy.
That makes total sense. So how do we approach these conversations with patients? It must be so challenging to kind of walk them through such a complex and life-altering decision.
It is. I think honesty and empathy are key. We need to be upfront about the risks and benefits of each option, the potential for complications, and, the long road to recovery that lies ahead no matter which path they choose.
Yeah.
It's also really important to involve the whole care team,
Right.
nurses, physical therapists, psychologists, to really provide that comprehensive support throughout this whole process.
It sounds like a true team effort.
It is.
And speaking of teams, let's bring this back to you, our listeners,
Okay.
who are, gearing up for those intense postgraduate exams.
Right.
How can we apply this knowledge to those dreaded exam scenarios?
Well, imagine you're in the exam room and you're presented with a case of a mangled limb.
Okay.
The examiners want to know your thought process. How are you going to approach this very complex decision?
Right. It's not enough to just memorize the scores and the guidelines.
No.
They want to see that you can think critically, weigh the evidence, and apply it to that specific patient scenario.
Exactly. They're looking for that clinical reasoning, that ability to synthesize information and then make a sound judgment.
So what are some key things we should be thinking about when we're tackling these exam questions? What are the examiners really looking for?
Well, I think it comes down to demonstrating a deep understanding of the principles behind those scoring systems,
Okay.
what each factor really means, why it's important, and how it contributes to that overall assessment.
It's like, don't just regurgitate the numbers. Show them that you understand the why behind those numbers.
Exactly.
Like, why is ischemia such a critical factor in that MetaSS score?
Right, because prolonged ischemia can lead to muscle necrosis, infection, and ultimately, a higher risk of amputation.
Right. It all comes back to those basic principles of tissue viability.
Exactly.
So if you can connect those dots for the examiners,
Yeah.
demonstrate that you're not just memorizing facts.
Right.
You're actually understanding the concepts. I think that's what's going to make you stand out.
I agree. And remember, those scoring systems are just one piece of the puzzle. The examiners also want to see that you can take that holistic approach. Considering things like the patient's age, their comorbidities, their functional demands, and even their personal values and preferences.
It's about seeing the whole patient,
Yes.
not just the injured limb. And that's a skill that takes time and experience to develop. But these exams are designed to kind of test whether you're on the right track.
That's right. And don't forget, the psychosocial aspects are huge.
Right.
How do you approach a patient who's just experienced, a potentially life-altering trauma?
Right.
How do you counsel them through that whole decision-making process? How do you support them through what's likely going to be a long and difficult recovery?
Those are such essential skills for any surgeon.
Absolutely.
But especially those dealing with trauma and reconstruction.
Right.
It's not just about fixing bones.
No.
It's about really helping patients navigate what is a major life transition.
Well said. And that's something that, no scoring system can capture. It's about that empathy, compassion, and the ability to build a strong, patient-doctor relationship.
Okay, future orthopods. Let's do a quick recap before we wrap up this deep dive. We've covered a ton of ground today. Initial management of open fractures, those crucial first few hours, the nuances of antibiotic selection, assessing tissue viability, and those all-important scoring systems for mangled limbs.
Yeah. We also talked about the complexity of deciding between limb salvage and amputation, all those factors to consider, and really the importance of involving the patient in that whole decision-making process. And of course, we can't forget about the reconstruction ladder with all its options for covering wounds and restoring function.
Man, this episode was packed with information. I'm sure it's going to show up on those postgraduate exams. And remember, all of this is based on the Ortho Made Simple notes from mokyingren.sg. Dr. Rokas, who recently aced his FRCS, has done a fantastic job of really distilling this complex topic into a very digestible format. Definitely check it out if you haven't already.
It's a great resource.
Yeah. All right, future orthopedic surgeons, go out there and crush those exams. And remember, whether you're dealing with, a simple fracture or a really complex mangled limb, approach each case with a clear head, a solid understanding of the principles, and, a genuine desire to help your patients achieve the best possible outcome.
Couldn't have said it better myself. Keep learning, keep asking questions, and never stop striving for excellence. Best of luck.